Hello and welcome to the Retina Radar. I'm Arshad Khanani, Managing Partner, Director of Clinical Research and Director of Fellowship at CRI Associates and Clinical Professor of Surgery at the University of Nevada, Reno School of Medicine in Reno, Nevada. I'm joined today by my friend and good colleague, Dr. Veeral Sheth, Director of Clinical Research at University of Retina and Macular Associates and Clinical Assistant Professor at the University of Illinois in Chicago. Welcome, Veeral.
Arshad, thank you for having me. Pleasure to be here.
It's been great knowing you, Veeral, for last 16 plus years, interviewing residency fellowship together and also collaborating on a lot of clinical trials and other projects after we started our practices. So excited to have you today. We'll be discussing the latest information, emerging clinical trial data, and real-world studies in the management of DME. Veeral, in this podcast, before we get started, we usually ask some fun questions about our guests. So first few questions for you. Tell us how you ended up doing what you do with your retinal diseases and surgery.
Yeah, it was a great question. I don't think I thought about ophthalmology when I started medical school. I didn't know much about it. And so I think like a lot of people, wanted to be, a pediatrician or primary care doc. But I'll tell you, it boiled down to just finding a really good mentor. And I kind of accidentally stumbled into this kind of elective ophthalmology rotation, met just one of the best people around, who was also happened to be a pediatric retina surgeon. And so I followed him around for a few weeks, and it was pretty fast where I realized that, look, I like what this guy's doing. I like, what he's able to do for people and their vision and the immediate impact he can have on people's lives. And pretty soon after that, I pivoted to ophthalmology, and the rest is history. Kind of followed and found just good mentors along the way, which is what kind of allowed me to get to this place now.
And who was that person, just to name them, if it's okay?
Yeah, it's a guy, Michael Shapiro. He's practicing still in the Chicagoland area. We touch base every now and then, and still just one of the best pediatric retinal surgeons you'll ever find. So, just a great guy. And again, just mentors are not just mentors for a finite period of time. They're mentors kind of all along the way. And so even now, if I felt like I needed some advice, I felt like I could go to him. And I think that's what being a great mentor is.
No, absolutely. And then, we all have our mentors that have driven us to do what we do. And now we are mentors to many fellows. You and I both have fellows, obviously, in practice and medical students to kind of get them excited about with your retinal care and also about preserving vision for our patients. What about your hobbies? I know you like to work out and travel. What is your favorite hobby?
Yeah, listen, I think traveling is my favorite. And I think, it's always been a passion. It's something my wife and I kind of bonded over when we were kind of, in med school together before we were married. And now it's kind of a passion that we're passing along to our kids. We just got back from a trip to Croatia. Just had a really great time just discovering and, learning about new cultures and customs and foods and all that stuff. So I think that those types of things end up being, something that we can all bond over and spend time on. And I think that's, I would say, primary passion because it can be shared with so many others.
No, I agree. That's actually my favorite hobby too, just travel around and learn from different cultures, try different cuisines and the nature. So, and of course, any time with the family is so important as we work so hard on a daily basis.
Yeah, well, and you and I have done some traveling together too. So that like I said, sharing it with others, including our colleagues, is fun.
No, definitely. So what's your favorite spot? You've been all around the world.
It's recency bias. I'm going to say Croatia was amazing. I'll tell you why. It's still relatively untouched, right? We were in Ireland together recently. Where you go to Italy, Greece, they're just so busy, and it was nice and refreshing to go to a place that wasn't just completely overrun. Had a good mix of cities, beaches, islands, all that stuff. And so I think when you see a place like that, it's fun. I mean, if you're going on a vacation, you want some peace of mind, calmness, and I think a place like that was perfect for me.
It sounds fantastic. That's what we look for. So hopefully we can do a trip there together in the future.
Yeah, we'll have to wait for an ASRS or something to pop up there, I think.
For sure. Okay, let's dive into a topic at hand, DME. You and I have a lot of patients with diabetic macular edema, a lot of younger patients, working age. We have great treatments in ranibizumab, in aflibercept in the past. Now we have faricimab, the first bispecific antibody. We have aflibercept 8 mg, and I think those are trying to address, better disease control, greater durability, because we know the real world outcomes are suboptimal in this patient population just because of non-compliance and other factors, including, other physician visits, including getting sick, the cost of care, missing work. So there's a lot of factors obviously there. So in terms of top line about aflibercept 8 mg, can you tell us a little bit about the 96-week data from the Photon trial for DME and some of the post hoc analysis that you found interesting that were recently presented?
I think just to take a step back, you're mentioning kind of these newer treatments. It's exciting, right? Because you and I have been part of these clinical trials. We've seen a lot of things not make it through, and so it's exciting now to get this kind of next wave of therapies. Aflibercept 8 mg being one of them. We were part of the Photon study, and so getting this 96-week data has been great. I mean, it's impressive data when you see, I think 84% of patients maintaining dosing intervals of 16 weeks or more. I think we're looking at even going beyond 16 weeks now, which is pretty impressive. I think that there's been some interesting post hoc data analysis looking at, I think at RWC that was presented, where we saw potentially 8 mg lasting 6 to 9 weeks longer than the 2 mg dose, right? And so, going back to one thing you mentioned, which is like we have great treatments, we have great therapies, but we still have a lot of unmet need for these patients. We know that in the real world they don't do as well as in clinical trials, and I think you touched on one point, which is durability. We need treatments that last longer so we can reduce the treatment burden on these patients, and we're finally seeing kind of what building on really great treatments. Now we have really great treatments that may last longer, and so I thought it was real interesting to see that this aflibercept 8 mg may last 6 to 9 weeks longer. I mean, these are the kind of incremental improvements we need. I think, look, when we look at durability as one aspect, we look at efficacy as another aspect, and so we want to see anatomic improvements. We want to see better drying. And so in post hoc analyses from Photon, we're also seeing less fluid reaccumulation with the 8 mg versus the 2 mg. We're seeing kind of meaningful visual anatomic improvements from baseline to 48 weeks, and hopefully we'll see that kind of go on to 96 weeks as well. And we saw, when you break it down to patients with 20/50 or worse vision, I think as expected, we see that those patients achieve greater visual gains and improvements in central retinal thickness than those with 20/40 or better vision. I mean, that's kind of what we would expect, but listen, we want to see the data bear that out, and we do indeed in the post hoc analyses. So I think these are just multiple data sets, and I think we're going to see even more coming out as meeting season evolves this year, on data coming out of Photon and just visual, functional, anatomic benefits that we're getting from a treatment like 8 mg versus 2 mg.
I think that's an excellent summary. And not much to add. I think, real world data is important, and we're going to dive into that later in this conversation. And of course, we're all kind of generating that data because the drug just had J code and it's relatively new. So what about faricimab? You're part of all the trials in the past. A lot of patients in Yosemite, Orion, whichever trial you were on for DME. What are your thoughts on dual inhibition of VEGF-A and Ang-2 for the treatment of DME? Obviously, we have seen significant data in terms of faster drying, absence of DME early with dual inhibition versus aflibercept 2 mg. What are some key takeaways from the data that you have seen so far, even some of the post hoc analysis recently presented at clinical trials at the summit?
We were part of the Rhine study, and so we've had the benefit of having patients that have been treated with faricimab for 5 years now, which is incredible. And so some of the key things I think from the data that's come out is, okay, going back to the durability concept, we know that 80% of these patients coming out of Yosemite Rhine can get to 12 weeks or longer durability in their dosing interval, 60% getting to 16 weeks. And I think that's relevant information. We want to counsel our patients on expectations, right? They want to know, doc, you're putting me on this medication. What can I expect, right? You and I we see patients every day in clinic, and they'll ask, well, how many injections am I going to need, or how often am I going to have to come in? And to be able to tell them with more confidence that, hey, look, we're likely going to be able to spread these injections out, and 60% of patients can get to 4 months between their treatment intervals. I think that gives them hope. I think it helps them buy into the treatment, and it improves compliance. I think when patients know that they're not going to have to necessarily come in every 4 weeks, but still get good outcomes. You mentioned something that we didn't touch on yet, which is like the rapid nature of the drying, right? And so what we see in Rhine and Roan is that we do see, when we compare faricimab to aflibercept, faster drying, and at almost 40 weeks faster when you look at kind of that 75th percentile of drying. So we want that, right? We know intuitively that when our patients have fluid, that's bad, and we are always aiming at drying those retinas out as quickly as possible and as effectively as possible. And so we know that if we've got a treatment such as something with a dual mechanism of action like faricimab, and we can dry them out faster, that's why I think these newer treatments are becoming first-line treatments, because we want, something that just works faster and better for our patients, because we think at the end of the day, when vision is the most important outcome, that's what's going to give us the best outcome.
No, I totally agree. I think disease control is directly related to visual outcomes long term. And, we want the disease control quickly and maintain the benefit or have sustained benefit. So, yeah, I mean, our experience is very similar to what you mentioned from the trials, is fast drawing and maintenance of disease control. And I think that's important for patients. And I think if we can have like a drug where most patients can go 3 or 4 months consistently, I think it resonates, as you said. I mean, I think patients are more compliant if they come in less often. So really great innovations, both of these new drugs for the field. Obviously, faricimab is not new now. It's almost 2.5 years in the US, and you and I have both utilized in clinical practice, obviously first line in our practice at this stage after going through difficult to treat patients, and we are still experimenting with aflibercept 8 mg to see if it's better than faricimab, similar to faricimab, or where does it fit. So more to come out in the future. Shifting gears a little bit, Veeral, port delivery system or port delivery platform is now called, obviously was FDA approved for neovascular AMD, was voluntarily recalled because of septum dislodgement issue. Now back, just back approved a few days ago. And obviously, while that was being done, they were fixing the issue. We saw the readout of Pagoda and Pavilion studies last year. I actually presented Pagoda at Angiogenesis, and the data is very promising in terms of disease control, in terms of visual outcomes, non-inferior to ranibizumab, 0.5 milligram given monthly. And so, what are your thoughts on port delivery platform with ranibizumab for patients with DME? Obviously, it's not currently FDA approved, but I would expect that there will be some decision about that later this year or sometime next year. So any thoughts on DME and treatment with sustained delivery, and where does it fit in?
So I think when it comes to PDS, I think first we're all excited that it's kind of being relaunched, because I think if you've been in these clinical trials, or if you've implanted this in patients in the real world, you'll see that that these patients are some of the most satisfied patients we have in our practice. And so I think there's two kind of data points in my mind from the Pagoda trial that really stick out. One is that patient satisfaction. We see 95% of patients getting PDS didn't receive supplemental treatment. And you ask those patients, the satisfaction is kind of off the charts. And so that is an important marker. I think the other one is when you look at these curves in terms of BCVA vision, you see that the patients that get the PDS implant with ranibizumab, they are equivalent to the patients that are getting monthly ranibizumab. And so, nothing has ever been better than getting monthly ranibizumab. Everything else is compared to that. And so when you have an implant that's a refill every 6 months, and you're matching that, you can just imagine that in the real world, these patients, if you can maintain that 6-month kind of treatment interval, but also maintain clinical trial level vision results. I mean, these to me are kind of the game changers we need, right? Because at the end of the day, I mentioned it earlier, but when you ask patients, the most important thing to them is vision at the end of the day, and they'll kind of do what they need to max out that vision. And so these types of treatments and these types of innovations, and like you said, hopefully this data will allow the FDA approval of PDS for DME. But these types of innovations are really what can help us get better real world outcomes for our patients.
No, definitely. And in the trial too, right? Like were you part of Pagoda?
Yes.
Okay, yeah. So exactly, we had so many patients in Pagoda, and what we saw that, I mean, the fellow eyes start to go, get vision-threatening complications if they didn't have DME or already had DME and required treatment and continue to require treatment. So all my patients that actually got, eventually got for delivery, whether, if they were in control arm, they were switched to it, they were so happy. Even, you mentioned the neovascular AMD data, they were so happy that they're waiting for the approval so they can get it in their fellow eye. So I think I totally agree with you. I think the patient satisfaction is so high with this, and I think sometimes it gets lost into the discussion about surgery and risk benefit profile. And the second thing you said is the sustained delivery benefit in having better visual acuity outcomes. In neovascular AMD, we have seen the 5-year portal data, and it's just fantastic. So yeah, I think looking forward to having it available for DME, and then I think it's a risk-benefit discussion. Younger patients with thicker conjunctiva and tenons, we may have less, conjunctival erosions and retractions if the surgery is done correctly. We actually saw it in Pagoda that there were no endophthalmitis at 1 year, so I think it was already much better, and all the, the surgical technique verification and improvements that we have done together, you're closely involved with that too. And I think that has really resonated, hopefully, in better safety. So next topic, I know you are very closely involved with the fluocinolone acetonide implant. This is, an FDA approved implant that can last up to 3 years, approved for diabetic macular edema in patients who don't have steroid response. Tell us a little bit about 3-year Paladin phase 4 study. I think you were one of the co-authors on it, and the safety and efficacy of fluocinolone implant in patients with DME.
I think it's an important topic that doesn't often get a lot of airtime, right? Because I think we're always talking about anti-VEGFs or dual mechanism and things like that. And steroids have been around for so long; they're just not the topic that kind of excites people. But what I'll tell you is, there is a place for steroids, right? I think that they do work, and I think if you pick the right patients, you use a treatment like fluocinolone 0.19, the implant, you can really reduce treatment burden. And so a lot of what we've been talking about is durability and all of these things that are surrounding kind of, better patient care through potentially fewer injections and fewer visits. This is kind of one of those ways we can achieve that goal. And again, it's not for everybody, so I think patient selection is important. And so one of the learnings from Paladin is if you do a proper, steroid challenge, and then you kind of weed out those patients that are going to obviously be steroid responders, and you focus this treatment on those patients that don't necessarily show IOP issues, then you can keep those IOP related events that we're always kind of worried about with steroids to a very low level. And so, what we looked at in the Paladin study was, okay, what type of therapies did the patient need after receiving a fluocinolone implant? And we saw that 25% of patients receiving these implants were supplement free at 36 months. So think about that. 3 years later, there's patients that are not needing really any other treatment. Now, this was kind of all-comer patients. And so you have to understand a lot of these patients were high treatment needs, high treatment burden patients. And so to be able to then reduce the number of treatments needed, by 3 years, eyes were receiving on average about 1.7 treatments per year. Again, so you're taking these high needs patients and really reducing the treatment burdens. Having patients in this study, I can tell you after receiving them, I had some patients that needed really no supplementation, some that needed a few. And so, but what I can tell you is on average, I think patients in general needed less injections over time after receiving this. And so I think with the proper selection, I think, again, there's a place and there's a patient that is potentially a good candidate for these types of therapies.
No, I totally agree with you. I think steroids are fantastic for DME because they address inflammation, right? Which is not addressed by anti-VEGF. And obviously, dexamethasone is also approved, and that is utilized a lot, sometime in combination and by itself. I think the anxiety comes to steroids, in terms of IOP spikes, right? So I think that's where the community obviously is concerned about IOP spikes and cataract formation in the younger patient population. So, what are your thoughts on the adverse events, and how do you tailor the treatment with steroids, keeping those two main adverse events in mind?
It's a real concern, right? Because if you use steroids enough, it's like anything else, when you're going to start seeing some of the potential adverse events. It's just a numbers game, right? And so, I think I kind of briefly touched on steroid challenge. If I'm going to use me personally in my practice, if I'm going to use a 3-year implant, like the fluocinolone implant, I'm generally testing them with an intravitreal dexamethasone implant first, right? I want to know for two reasons. I want to see, is there efficacy with this intravitreal steroid that I'm giving the patient? And then what happens to the pressure? Is there some kind of signal or IOP response? So after dexamethasone, I see him again in 6 weeks, check the pressure, and if there's any real indication of an IOP elevation, then I may be less inclined to proceed with the steroid. But I'll tell you, there's also patients that receive anti-VEGF after anti-VEGF, and we really see no improvement, especially these chronic DME patients. But you give them a little bit of steroid, and really they dry up nicely. And so those are the kind of patients where I'm really kind of keyed in on and potentially identifying as patients that would benefit. But you gotta counsel them. You gotta think about potential adverse events, but you gotta weigh it against, the meaningful efficacy of drying that retina out. So I agree with you. I think it's a challenge. I think it's something we have to keep on the radar. I think it's something we have to counsel our patients about, and it's something we have to be vigilant about in checking IOP and making sure that we're watching that. Cataracts don't bother me as much. I think over the last 10, 15 years, I think I've become less worried about cataracts. Again, I counsel patients that if we don't dry your retina, none of the other stuff matters. And if this is the only way we're going to get there, or only way we're going to get there effectively, then we'll make that trade-off and say, look, I'd rather have your retina dry. We'll take care of your cataract when the time comes. And that's going to give you potentially the best outcome at the end of the day.
No, I think very, very well said. I mean, I think it's a risk-benefit discussions with the patient, and I think some of those IOP, events are predictable at times, and you can manage them appropriately. Okay, so last topic at hand, real-world experience with aflibercept 8 milligrams and faricimab. Obviously, much larger data set, global data set with so many different trials for faricimab because it's been out for 2.5 years. Just give us a little bit overview on what are some of the key findings from the recent experience with the aflibercept. Obviously, the data we have seen so far for real world has been on neovascular AMD, but we have a host of data on DME with faricimab.
So we'll start with the aflibercept 8 milligram. Like you said, we're just scratching the surface. At the clinical trials at the summit meeting, there was a nice presentation. I think probably the first one showing any real world data from 8 milligram aflibercept. Again, like you mentioned, that's for AMD. But what we saw, at least in that, is that a third of the patients that were switched to 8 milligrams were highly responsive and did well. And so, we saw potentially extended dosing intervals. It's a small group of patients, 40 patients, but this is the kind of stuff that we're kind of keyed in on as clinicians because we're just starting. I think you used the word experimenting. We're just starting to use these new treatments, this one in particular, in our practices. And so I think collecting this data, getting more patients, we're going to learn a lot more about how this treatment is working in the real world. But to your point, we've got a lot more data on faricimab. So far retina DME, for example, or Tahoe, which is what you've been working on. So when we look at far retina DME, for example, we're seeing that patients that are put on faricimab, their vision is improving by about 5 letters after 5 injections in treatment naive eyes. We're seeing good disease control, disease control with less than 320 microns, patients increasing to greater than 50% after 2 faricimab injections. So we're seeing the drying effect. We're starting to get a better idea of what happens to patients when we switch them. which is what a lot of the initial patients are in these new treatments. I think with the aflibercept 8 milligram, we're going to see the same thing. Initially, we're going to see switch patients, and I think we're going to learn a lot from that. So I still think that there's a lot of data being generated that we're going to see, waiting to see kind of what Tahoe shows and learning from that and from our peers and how they're using these treatments.
Definitely. So those are great comments, Viral, and great discussion. I really appreciate it. So before we close the podcast, a couple of more personal questions. What is your career achievement that you are most proud of?
Listen, I think for me, it's not a one achievement. It's the fact that we teach and train fellows. I think for me, this is kind of bringing our conversation back full circle. You know, mentorship is what got you and I to where we are now, and has helped us develop the passion for what we do, has helped us develop our clinical trial programs, and I think that is something I enjoy passing on to others. And just kind of watching them and their interpretation of what you teach them and how they synthesize all this information and take all the learnings from different mentors and become their own kind of retina specialist and define their own careers. And so, you know, you and I have been doing it for long enough where now our mentees are becoming mentors to others. And so it's fun to watch that kind of pipeline and that continuation. Medicine's always been that kind of a field, right? Where we're teaching each other and constantly training each other and passing on that information. So for me, that's been kind of the best part of my career so far.
No, I totally agree. I think the satisfaction is so high when you see these trainees coming in and, do a fellowship and go from not knowing much about surgery or clinical practice, and then they're superstars after 2 years. So yeah, I totally agree. I think this is really something that is very satisfying. And your career just started. You're kind of mid-career, like I am. We have another couple of decades to go, hopefully. Once that time comes, what do you want to be remembered as once you retire?
Yeah. Wow. That's a big one too. That's like the 30,000 foot question. Look, I think, you know, you and I have been so involved in this field. I think what I would hope for is that when we look back, when you and I are at our retirement party in 20 years, celebrating, I hope we can look back and say we had a positive impact on the field, right? We're so kind of in the middle of it right now that sometimes I think we lose perspective on the big picture and where things are going and what direction they're moving in. But I do think that we are helping, along with many others, to kind of define what's happening in our field and to shape treatments, not only the ones that are getting approved today that we've been talking about, but the ones that are going to come for years to come. And that to me is going to have the biggest impact, right? You and I can see a patient, we can see 10 patients, we can see 50 patients, but if we can do these types of things, we can really have an impact on the field in a positive way. And that is, I think, something we can be proud of.
Thank you, Veeral, for excellent discussion. I think our audience learned a lot about the evolving, space of DME and how we can use current treatments and exciting things coming in the future. We also learned a lot about your personal life and your hobbies and things you have done in your career and things that make you proud. So thank you to the audience for listening. Please remember to take the post-test and evaluation to receive CME credit and to tune in for additional episodes within this podcast series. Viral, thank you again for being here with us today.
Thanks, Arshad. Appreciate it.